being delivered by no less a person, the legend in the nephrology and hypertension, Dr. George L. Bakrish. And he is the professor of medicine and director at the AM Heart Associate Comprehensive Hypertension Center. Published over 900 peer-reviewed papers and book chapters on hypertension, nephropathy, and its progression. He is the editor, co-editor of 22 books. He's the co-editor of the third and fourth edition of the Hypertension, a companion to Brownwell's book on the heart. He has served on the Cardinal Advisory Board in the FDA and many of the guidelines, JNCs, and I'll be taking much time to introduce him. Now with this, Dr. Bakrish, I welcome you on behalf of me, on behalf of my two other chairpersons, Dr. Sachin Chitawar and Dr. Isha Bansal. You saw the photograph, beautiful photographs. They'll be taking over from me after your talk is over for the discussion. The first talk, my dear friends, is on a very important contemporary challenge. Dr. Bakrish is going to speak to us regarding the resistant hypertension, which is a big problem. How do you diagnose it? Pseudo resistant hypertension or true? And I don't know if you, but it's a great problem because if you exclude the secondaries, in 75% of the essential primary hypertension, we do not have a cause for the resistant hypertension. And I think we are looking forward to listen from you, Dr. Bakrish, regarding the detection, the evolution, and the management of this very important entity, hypertension. I think, Sachin, you will take over after the talk is over for the next talk, to introduce the next talk, and then Isha will take over at the end for the question and answer session. Over to Dr. Bakrish. A hearty welcome.
Thank you. Thank you very much. And thank you for the invitation. And thank you to everyone. And I'm going to sneak in and give you a hint as to what guidelines are coming up. And I heard some talks from my good friends here in the US. So guess what? I'm going to sneak right in and just tell you that, remember, okay, well, let me find my, hang on. Jesus. Okay, hang on. Number one, let me give you a hint here. The guidelines for next year. SGLT2s pretty much have to be put in the drinking water. As you heard correctly, this is a lifelong disease and you can use them down to GFR of 20, no problem. These are cardiorenal risk reducing agents that happen to lower glucose. And in fact, we know that they work even if you don't have diabetes. So they need to be used, period. That's point number one. Point number two, my good friend Kathy Tuttle was talking about using the non-steroidal mineralocorticoid receptor antagonists. Those are also going to be in the 2022 guidelines. And this is, make no mistake, this is not your mother's Spiro. That is another novel class of drugs defined by the FDA as a novel class of drugs, not related to Spiro, not related to finerenone. So keep in mind, those are going to be in the guidelines for 2022. That's what's coming. Now, resistant hypertension, here's the bottom line. You need to think about this in a different way than garden variety hypertension. The definitions are here. Less than 130/80. You know this. You have to be on 3 drugs, maximally dosed, not 5 of lisinopril, not 12.5 of hydrochlorothiazide, and 2.5 of amlodipine. No, that is not what you want. You want 10 of amlodipine, you want maximal dose ACE or ARB, and you want at least 25 of hydrochlorothiazide or something else. And then you have to make sure the patient's taking the drugs. Are they taking them? And if they are, then we can talk about resistant hypertension. Very important to understand that. These are the definitions by the ACC/AHA. European guidelines, which you may have read, not quite the same. They're still more traditional, but nevertheless, this is what's out there. Now, all of the following have to be true for someone to have resistant hypertension. Are they on a low salt diet? Big deal in India, because as you know, diet's not really low salt. Very important. Are they taking their meds? Are they sleeping well? This is a big deal. Are they getting 6 to 7 hours of sleep every night, uninterrupted? If they are, great. If they're not, do they have sleep apnea? Do they have anxiety? Do they have some other problem? That will interfere, and that will cause big fluctuations in blood pressure through the day. This is a big deal, big deal. Now, we're going to talk about this. If you're on 3 drugs, are you really on the best 3 drugs for lowering blood pressure? There are differences. There's no question about it. I'm going to show you this as we go on to this. And you got to rule out secondary causes. Primary hyperaldosteronism, unappreciated, by far the most common cause, secondary cause of hypertension and responsible for resistance. And not everybody has hypokalemia. You can have normal kalemia and have primary hyperaldosteronism. So you got to think about it. So this is quick, just a review, just to remind you, the diet is critical. By the way, high salt diet, you can forget about ACEs and Arbs working. You've shut off the renin-angiotensin system. Those drugs are not going to work. You gotta have a low sodium diet, and low sodium, 2,000 milligrams. We're not talking no salt. You got to think about how these drugs work, and you got to think about treatment resistance. And this is a chart that kind of goes through things that affect blood pressure. Volume, we already talked about it. Heart rate, high heart rate is going to cause high pressures, indicating high sympathetic tone, something to think about. The renin-angiotensin system, we've already talked about. Adherence to medications, sleep, we've talked about all this. Very important points. This is an evolution of the guidelines. I just thought I'd show it to you, have some fun. But there's 129 different antihypertensive medications. 129. How can you not screw up? No, you can screw up. And guess that's if you don't know what you're doing. So you got to know the pharmacology and you got to know this data. That's why I'm showing it to you. This is the holy trinity of therapy. ACE or ARB, CCB, diuretic. If you've done this well, you should be able to control about 80% of people with hypertension, maybe 85, depending on how you define it. And if that, the remaining is the true resistant hypertensives. This is just to show you from the clinical trials. This looks at hypertension, diabetes, and kidney disease clinical trials, the average number of blood pressure lowering meds, average number. You can see nobody's on 1 drug. Everybody's on 2, and most people are on 3. So keep this in mind. The approach, should you max out the dose? Well, for ACE or ARB, yes, but for everything else, no. Because this study looks at different classes of agents, including the ACE, by the way. And what they did is they either doubled the dose or added a second drug at a lower dose and looked at who achieved blood pressure lower. In every case, didn't matter, every case, if you doubled the dose, you got less blood pressure lowering than adding a second complementary drug, mechanistically complementary. So this is very important. And in fact, the American Society of Hypertension put out guidelines 10 years ago on acceptable combinations to be used in hypertension. It reduces the pill burden as a single pill, and they have synergistic effects. Very important point. And don't be using combinations, ACEs and ARBs, ACEs and beta blockers. They don't work for lowering blood pressure. Now, this is in the guidelines. Even 2017 guidelines are talking about combination therapy. They're talking about combination therapy. The British guidelines, Brian Williams, a good friend, put it in your face. You start with combination therapy because adherence is so bad. Just start with a single pill, 2 drugs, and call me in the morning. And that really is going to improve hypertension control rates. You'll see in a couple of years. No question about it. So this is the approach. So let's take a look at thiazide diuretics. Let's take a look at ARBs, and let's take at CCBs. They're not all the same. This is a paper we did with Brian Williams looking at diuretics and different guidelines and looking at resistant hypertension and essential hypertension, or primary, now called primary hypertension. And you can see here for resistant hypertension, we're not talking about hydrochlorothiazide. We're talking about indapamide. We're talking about chlorthalidone. So very important to understand. Now, This is 24-hour, this is mean office blood pressure, but they also did ABPMs in this study. Hydrochlorothiazide versus chlorthalidone. You can see here very clearly chlorthalidone gave you the benefit over hydrochlorothiazide. You get additional blood pressure reductions. This is a study we did in referral patients. So this is a clear office study. Everybody was referred for resistant hypertension. Everybody was on hydrochlorothiazide. All we did is change hydrochlorothiazide to chlorthalidone at the same dose. And then we brought them back 6 to 8 weeks later. You can see blood pressure went from 152 down to 145. Significant reduction just by substituting diuretic, not adding drugs, not changing doses. Now, ARBs. There's a bunch of ARBs. You can see here they are. And the question is, are they all created equal? They have different indications. Different companies did different studies. Some are good for the kidney. Some are good for the heart. The bottom line, they're all good for the kidney. They're all good for the heart if you control blood pressure. So what are the differences? Here's a 24-hour ABPM study in 984 patients. Valsartan 320, azilsartan 40 or 80. I don't think I have to discuss this. This is obvious. The data speaks for itself in terms of magnitude of reduction. Now, what about against an ACE inhibitor? Azilsartan against ramipril. Here you go. Take a look at the graph. I don't think I have to say anything. The data is very clear on what's giving you the best blood pressure reduction. Now, we went back and we looked at comparisons with olmesartan, comparisons with valsartan, against valsartan in people with diabetes, normal glucose, and people with pre-diabetes. And here's what we found. So again, across the board, azilsartan gave you better blood pressure reduction. In some cases, not so much. In some cases, a lot, against valsartan and against olmesartan. Although olmesartan, I have to tell you, is essentially the same as azilsartan. If you look at the conclusion, all the data, they're essentially the same. There's a 2 millimeter difference. I mean, they're essentially the same. But valsartan, losartan, forget it if you want blood pressure. Now, why? Well, if you look at the bindings, it has nothing to do with half-life. If you look at the binding, that's the key. Look at the left, that's before washout. So all of them look good, okay? But look at the right. This is after washout. Azilsartan is still tightly bound after the washout period. The rest have faded. Even olmesartan has faded at the higher concentration. So again, keep in mind, there are differences in binding. And in fact, losartan, about 57% binding, azilsartan, about 85% binding. So big difference in binding of the AT1 receptor. And in fact, when you look at this over time, going out 4 hours, you can see during the washout period, this is the same data, just pictorially different. All the open bars and circles and whatever are washout. And you can see azilsartan is still up here, whereas everything else is down here. Here's olmesartan, and then the rest are down here. So that's another way you can get blood pressure control. And then what about the CCBs? There are differences between amlodipine and nifedipine. And the differences are small, but they're there, 3 millimeters, 4 millimeters, amlodipine not being quite as good. Now, overall, amlodipine is a far better CCB than nifedipine, no question about it. But for blood pressure, there are differences. Can you combine CCBs? The answer is yes. This is a study that was done in the 1990s. Many people don't know about this, but you can combine a dihydropyridine with a non-dihydropyridine. This looks at diltiazem and verapamil with nifedipine, low doses. And you can see here, systolic pressure, nice reductions by both. And then over time, diltiazem has a better duration of effect. And we do this in people with asthma that can't get beta blockers. We do this in people that can't tolerate beta blockers, and it works quite well. Now, pathway 2 says spironolactone is the number 4 drug. We put it in the guidelines as the number 4 drug. No question about it. Oh, this study, GFR 84. Whoops. You don't have to worry about potassium. GFR is 84. Can you do this in somebody with GFR 45? Well, if you use potassium binders, sure, why not? So what are the 2 most common non-disease causes Non-disease causes of resistant hypertension. Number one, white coat, anxiety. This is a big problem. And poor medication adherence. Could be due to dementia, could be due to the patient being passive aggressive, not wanting to take it. Nevertheless, you have to figure this out. ARBs are the best tolerated. This meta-analysis shows best persistent drug ARBs. And adherence, it's been tested by a number of studies. These are two seminal studies where they actually measured urine metabolites in one. The other one they didn't. They actually just looked at pill counts and other things. Bottom line, both studies showed 45% adherence. 45%, 4-5. So the majority of people are not taking all the BP drugs. This is a big deal, and you need to get to the bottom of it. Sleep is huge. And I told you this already. This is a review on sleep and blood pressure. And here's the bottom line. Less than 5 hours of sleep is going to be associated with exacerbation of hypertension, exacerbation of movement of hypertension in terms of variability. And here you go, the Nurses' Health Study, 10-year follow-up, 10-year follow-up. If you're getting 6 hours of sleep, 30% relative risk for coronary heart disease events. If you're getting 5, 82% increase in coronary heart disease events. Not good. This is a study we did, recently published, where we took people that had sleep difficulties, nothing else, had large fluctuations in pressure. All we did is fix their sleep. That was it. And look at their blood pressures. Very, very impressive. This is not sleep apnea. A lot of these people had sleep apnea. They were on the blower. That was not it. We got them better quality sleep, getting to sleep and staying asleep. That's the big deal. Now, this is from the guidelines, Hypertension, December 2018, that we published on resistant hypertension. And this goes through everything I just said in great detail in terms of the way to approach these patients with drug therapy, lifestyle, etc. And you can see the last choice, the last resort, is the potassium channel opener, minoxidil, which if you go to, and I prefer that over hydralazine, because you can get by with low doses, and hydralazine has a lot of side effects. So I think if you then look at what else you got all these drugs and everything, so everybody's talking about denervation and all that. Not ready for prime time, not approved in the US, approved in Germany. And this is a summary of 24-hour ABPM studies with different approaches to denervation. Bottom line, denervation, you get a 7 to 8 millimeter additional reduction in blood pressure. That's it. You're not cured. So here's your choice: denervation or spironolactone, or denervation or 2 additional drugs. I mean, that's kind of what you're talking about. It's not what people think, and it's very expensive, and it's a procedure. There's baroreflex therapy that's approved for heart failure and started off for hypertension, but it was an evolution. The carotid baroreceptors are critical and better, you get better results in denervation. This is the original on the left. So you can see, kind of scary, very cumbersome. And we did a study with that, and I'll show you the results in a minute. And then you got the new device on the right. That battery lasts 3 years. The battery on the left lasts 6 months. And the little device is on one side of the carotid. And again, much cleaner. You can see here, when you turn the magnet on, you get a nice reduction in the blood pressure. And then you turn it off, it goes up. You turn it on, it goes down. Very predictable. I've got people I'm following now 11 years after this was done. They're still doing well. This is the trial, the pivotal trial. We had open label, and then we had a device off. And then we evaluated him for 6 months and then turned everybody on. And what we found, this is who came in. You had to be on 3 drugs with a BP above 160. And we excluded people with atherosclerotic disease, basically. So we had an efficacy and a safety endpoint. And there they are. You can see them. And these are the criteria. These are the baseline characteristics. 5 meds. People are on 5 meds. Blood pressures were at almost 180 over 100. Very high pressures. And you can see this is the final result. The efficacy endpoints were good, but it was a safety issue in terms of procedures that you can see in red. And that's why the FDA didn't approve it. The company left, went to Europe, got it approved in heart failure, and now they're looking at hypertension. But you can see the long-standing effect. This is going out over a year, in fact, going out years. You can see blood pressure reduction was maintained. Side effects, year 2, we had a 3% incidence of carotid stenosis. Otherwise, everything was fine. And you can see that in this 207 patients. So putting it all together, you need to select your drugs carefully. You need to make sure patients are adherent. You need to make sure the combination therapy can be used because it'll improve adherence, and you got to focus on lifestyle. Spiro is your 4th drug if the patient can tolerate it based on kidney function. Don't forget sleep, very important. And if the patient has money and they're desperate, they can go to Germany and have an interventional approach. That's all I got for you, and be happy to answer any questions or comments. Thank you.
Very practical and very interesting talk that you gave regarding this resistant hypertension. Also did refer to the guideline. Thank you very much. Now I'll request Sachin and Isha. You can start the question session, then I'll take over. Isha, you are visible now. Sachin must be there. Isha, would you like to ask any question, or I'll start? You will take over from me. Isha, you are muted, I think. Not audible.
I'll ask in the next session, so we'll take over to the next session.
Okay. I think I just wanted to know that we had this concept of A plus C plus D, ACD, before calling anybody, and you also showed that beautiful triangle, and you had said the 4th drug beyond this is the spironolactone, and you said that beyond this there are some other drugs which you also highlighted. Where do you place the baroreceptor reflex issue that you so beautifully highlighted with a lot of examples? Where do you bring it in? All along the course of therapy, or beyond certain number of drugs?
That would be beyond a certain number of drugs. That's a last resort. That's in people that you've got on 4 or 5 drugs. Their pressures are still 170, 180. And the problem is it's not approved. And so when it gets approved, that's what I would do before denervation, to be completely honest with you.
Dr. Bakris, you are a living legend on hypertension. I just want to know, how often have you found that the resistant hypertension, so-called, was actually not resistant hypertension, it's pseudo-resistant hypertension, because as you rightly pointed out, because of the dietary indiscretion, of the drug non-adherence, etc., etc. How often did you find that's the cause?
Well, I can tell you that if you really look at true resistant hypertension in people doing everything correct, it probably in the US probably is about 5 to 7% of patients. It's not very high at all. On the other hand, if you then look at people called resistant hypertension, probably 25, 30%. So true resistant hypertension is not that common.
Okay, and of course you are excluding all the secondary causes, known causes.
Oh yeah. All secondary causes are excluded. I will tell you, primary hyperaldosteronism, it's out there. We're seeing a lot more of it, and we've always looked for it, but we're seeing more of it because we're looking more aggressively. So you have to think about it.
And how often do you encounter? I mean, in our country, white coat hypertension is actually a bothersome issue, and we do not have access to home BP monitoring or the ABPM. Now, how often do you think that the white coat hypertension gives the level wrongly as a resistant hypertension?
I think it's actually a lot more common than you think. One of the things you can do if you don't have home monitoring, if you can do this, is to take the patient and put them in a quiet area, let them sit there for 15 to 20 minutes. And basically after 15 to 20 minutes in that area, go back, hook up the blood pressure monitor, and have the machine, if you can program it to go off by itself, and then you'll see the difference. The other thing is you have to measure the blood pressure 3 times consecutively. So have the patient sit, if you can, for 4 minutes, and then measure it 1 minute apart, and take the last reading. Don't take the first reading. And then you'll see, especially if it's 15, 20 millimeter difference, no question, that's white coat.
Very good. And Dr. Bakris, you gave a very, you told us the secrets of the satans, and you said Agila Satan is almost, it's the best, possibly the best, if I've understood correctly. The BP lowering is almost equal to Olma Satan, but in some studies, Olma and Telma are also equally effective in reducing blood pressure. So if you have to choose between Telma, Olma, and Telma Satan, which one will you put as the more effective drug?
I would say based on my experience.
Yes.
Based on my experience, I think all three of those are very good. And I use all three. But I will tell you, I have taken people off Telma and put them on Azilsartan or Olmesartan and gotten a little bit better blood pressure control. Not much, maybe 3 millimeters, 4 millimeters better, but a little bit better. Telma, when it came out, I love Telma because it really had a lot of benefits, but these other agents are further newer and have better binding. So I will tell you, I have a reputation in Chicago because I get these patients referred to me, and I put them all on Azilsartan, and they all come back much better controlled. So I think there's something to be said for that.
Yeah, I think it's a great message for our country, Dr. Bakrish. I just wanted you to compare and contrast the hydrochlorothiazide vis-a-vis chlorthalidone, which got a new life. And one of our colleagues was also instrumental in giving the chlorthalidone story to the world. And you must have met him. He spoke about it very eloquently. So how do you compare and contrast these two?
So chlorthalidone has active metabolites, and chlorthalidone actually lasts 44 hours. Hydrochlorothiazide with metabolites lasts about 11. So it's a much longer acting. Indapamide, by the way, not to be left out, is also good, lasts about 24 hours. And so there's some very good opportunities here for other options.
Sir, one quick question to Dr. Bakris. Sir, you mentioned the role, one of the factors being anxiety in patients with resistant hypertension, and the white coat hypertension also is partly related to anxiety. So normally now we are kind of keeping beta blockers at far end of the options. So you think that these patients can be candidates for adding beta blockers early in the course of disease, or you still want to keep them?
Yeah, I know where you're going with this. I can tell you I've tried that. And what ends up happening is the patients complain because then they don't feel right. And to be honest with you, I use benzodiazepines in those people. I don't think beta blockers are the answer. And I think if you try to chase blood pressure from anxiety with blood pressure medicines, you will always lose. That's been my experience. So I use very low dose like clonazepam at very low doses, PRN. I try to educate the patient as to what's making them anxious and not to take their pressure at that time. Take that medicine, calm down, do some breathing exercises, some yoga. That actually works quite well if the patient is willing to do it.
Isha, you want to ask something?
Yeah. So, like regularly in ICU, in medical ICU, so we see the CKD patients who are maxed out on prazosin, then arcamine.
I'm sorry, I lost you.
You're muted. You're muted, Isha. Dr. Isha, you're muted. Yeah. Please ask the question again.
Yes, very good evening, sir. So in ICU setups, like what we see in CKD patients, like we see many patients maxed out on prazosin, then maxed out on arcamine. Like what else can we use for these patients to bring out? Like it's very expensive for Indian patients to take these medications also, like prazosin and arcamine, including other medications also. Still they has this resistant hypertension, which I can call them like, instead of a pseudo-resistant thing, they actually have this resistant hypertension. So what else can we use for these patients, sir?
So prazosin is not a very good blood pressure lowering drug. And
Okay.
it also has tolerance. So I don't use prazosin at all. I would say in the ICUs here, they use a lot of labetalol intravenously. And they also use clobidipine, which is a CCB. So if you have access to an IV CCB, those work well together. Switching them off amlodipine at 10 milligrams with carvedilol and I've gone as high as 50 BID, a diuretic, depending on the kidney function. So I like torsemide because it's long acting and it's good for blood pressure. And then, pick the ACE or the ARB that you have access to that reduces blood pressure well. And any of that combination, that should help you. But I have used minoxidil. I have used hydrolysine. So, I mean, that's it. But alpha blockers are not used over here.
And in these like ICU setup, like do you prefer giving nitroglycerin or labetalol infusions, or like you usually start with a?
I won't use nitroglycerin. Unless you have coronary disease. But labetalol, yes. IV labetalol works very well.
Yeah, both.
I have two questions for you, George. One is as an extension to what Dr. Isha just asked you. Very often when we have patients with CKD, ESRDs, and they're already on 5 and 6 antihypertensive agents, and yet you're not getting adequate control. And these are not hospitalized patients. These are all outpatients. And we tend to still have their, they're taking very high doses of these medications, and yet their blood pressures continue to be high. Can we accept that? And what happens to them in the long run, when you keep them at the higher level, despite the fact that you're taking so many medications?
Yeah, you should not accept that. You really should try to get them down. And minoxidil, for me, even if you have to go to 10 BID, as long as they've got good diuresis on board and good heart rate limiting agents on board, should work well.
And your patients with renal denervation, how long do you get a sustained control of the blood pressures? Do you see any changes? What happen, maybe after 5 years or 10 years, what happens to these patients?
Well, they haven't been followed for 10 years yet, but for 5 years, it looks like it's pretty sustained. Again, not drama, but you're getting, 7 to 10 millimeter reductions. So it's equivalent to 1 or 1.5 meds.
Bakris, you said about the addition of 2 drugs in the next guideline. I mean, I just wanted to know if you can share the status of SGLT2, Sundar is here, SGLT2 inhibitors, and the status of MRA. MRA.
So SGLT2 inhibitors, I was talking about the diabetes guidelines, not the blood pressure guidelines. But blood pressure guidelines, no, these are not going to be in any blood pressure guidelines. This is diabetes guidelines. But in the diabetes guideline, hypertension, finerenone is not going to be in there because it does not lower blood pressure. That's the key. This drug works independent of blood pressure reduction. The blood pressure reduction you get with finerenone is like 2 millimeters, 3 millimeters, not very antihypertensive. I was referring to the diabetes guidelines.
Guideline. And do you believe, of course, will you be coming to the next talk on the relation to the diabetes?
Unfortunately, I can't. Because I have a conflict and I have to get back to the other thing. The timing was bad, but I promise next time I will be here for
Dr.
both.
Das,
so I'm sorry.
We're going to have Sundar, who's going to step in for Dr. Bakris as a second lecture. So, Dr. Bakris.
All right, I'm sorry. I'm very sorry.
No worries.
Oh, no, that's okay.
Next
Thank you
time,
very
don't
much,
send
George.
me Eastern time. Don't send me Eastern time. All right.
No
very
worries.
good. Thank you.
Thank you for being
George, how are you? George.
I'm all right. How are you?